Welcome back to the Deep Dive. Today we're doing something a bit different. We're focusing on just one really complex medical story.
Right, a single case study.
Exactly. A deep dive into a patient facing systemic sclerosis, or scleroderma. We want to unpack how a chronic, kind of slow-moving autoimmune disease can suddenly explode into a life-threatening crisis.
It's a critical point to understand.
Our focus is a patient named Nancy. She's 38, a teacher. And if you just looked at her profile, non-smoker, no big family history of these kinds of issues, you wouldn't expect this.
She seems healthy on the surface, but underneath, her body was, well, setting the stage for a major systemic event.
And this case really shows the stealthy nature of scleroderma, doesn't it? Most people just think skin hardening.
That's the common perception, yes. But it's so much more. We're using this case to see how it impacts, I think, 6 major areas: skin, GI, lungs, blood vessels, kidneys, and the immune system itself.
And crucially, how doctors had to react instantly when she hit what's called scleroderma renal crisis.
A true emergency. Our goal today is really to trace that path, from a seemingly minor issue 5 years back, right up to this critical point just a couple of weeks ago.
Okay, let's start unpacking that timeline, because the buildup is key here. We go back 5 years before she lands in the hospital. It starts with something that sounds almost, well, harmless. Raynaud's phenomena.
Raynaud's, yes. It's often the first clue, sort of the canary in the coal mine for scleroderma.
So what was she experiencing?
For about 5 years, Nancy noticed her fingers turning really white, sometimes blue, especially in the cold. Now, lots of people have Raynaud's independently.
Right.
But in someone who later developed scleroderma, it's an early warning sign. It signals underlying damage to the small blood vessels, which is, fundamental to this disease.
And did it stay the same over those 5 years?
No, and that's critical. She specifically mentioned it had gotten noticeably worse just before this whole acute crisis kicked off.
Okay, so the microvascular damage is building silently. Then, maybe about a year before the crisis, the skin symptoms really start showing up. What are those classic signs?
Well, you start to see this progressive tightening, a thickening of the skin. For Nancy, it was initially over her face and hands.
Which leads to that specific finger appearance.
Yes, what we call sclerodactyly. The fingers become sort of tapered, stiff, difficult to move. She also developed these painful sores, digital ulcers, and little pitted scars right on her fingertips.
Which is direct evidence of
poor circulation, ischemia, essentially, tissue damage from lack of blood flow.
And the face can be quite affected too, right? It wasn't just the hands.
No, definitely not. And this points towards the diffuse type of the disease. Nancy developed microstomia, that's where the skin around the mouth tightens, making it hard to open fully.
Wow.
Yeah, and it changes facial expressions because the skin just doesn't move normally. We also saw telangiectasias.
Those are the little spider veins.
Exactly, those small, visible, reddish blood vessels, often on the face and chest. They're another sign of the vascular abnormalities happening locally. All these skin changes together really signaled this wasn't a mild form.
Okay, so skin and vascular issues are clear. Then, moving inwards, about 8 months before the crisis, the GI tract starts acting up. What happened there?
Primarily, it hit the esophagus. Scleroderma affects smooth muscle, and the esophagus relies on that to push food down.
So, difficulty swallowing.
Yes, dysphagia, especially with solid foods. And she also had really bad, persistent heartburn and reflux, the kind that over-the-counter stuff just wasn't touching.
That tells you the disease is internal now, not just skin deep.
Absolutely. It's actively attacking the internal organ systems.
A tough symptom to live with daily, I imagine. Then, 6 months out from the crisis, the lungs get involved.
And this is always a major concern, a big red flag in scleroderma.
What were her symptoms?
Progressive shortness of breath, especially when she exerted herself. Dyspnea. And it came with this dry, nagging cough.
Did they try standard treatments?
Yes, but crucially, things like asthma inhalers did absolutely nothing. When you have a patient with known scleroderma signs developing breathlessness like that, you immediately think, okay, is this interstitial lung disease, ILD, or maybe pulmonary arterial hypertension, PAH?
Right, serious lung complications.
Very serious.
Okay, so that's a lot of damage accumulating across different systems. Now, there's one more piece from her history. You mentioned 2 early miscarriages. Why is that potentially relevant here?
It's relevant because it might hint at the broader immune and vascular picture. Recurrent early pregnancy loss can sometimes be linked to something called antiphospholipid syndrome, or APS.
Another autoimmune condition.
Yes,
Yeah.
one that involves blood clotting problems. Now, Nancy didn't have a formal APS diagnosis, but that history suggests perhaps an underlying tendency towards abnormal clotting or vascular inflammation. It just adds another layer of complexity, showing how widespread the autoimmune disturbance might be.
Okay, so we have this 5-year backdrop. Vascular changes, skin thickening, GI problems, lung issues, starting a slow burn. But then everything changes in the 2 weeks leading up to her hospital admission. The slow process suddenly hits fast forward.
Exactly. It accelerates into the scleroderma renal crisis.
How did she actually present when she came in? What did she look like? What were her symptoms?
The presentation was dramatic. This is a full-blown medical emergency. The symptoms were classic for rapid kidney failure:
Gotcha.
swelling in her legs, pedal edema, puffiness in her face, severe, really bad headaches, and she wasn't producing much urine oliguria. Her body was essentially retaining fluid because the kidneys just couldn't cope, couldn't regulate pressure or filter waste.
And I bet the vital signs were alarming straight away. What numbers really stood out?
Blood pressure was the biggest shock. It was sky high, 190 over 120. That level of severe sudden hypertension in someone with kidney failure points directly to the specific type of crisis. It needs immediate, targeted treatment.
Not just generally high BP.
No, this is characteristic. She was also tachycardic. Her pulse was 110. And slightly hypoxic, her oxygen saturation was down to 92% on room air. Her heart and lungs were clearly struggling under the strain.
So beyond those vital signs, what did the physical exam reveal about the organ damage scleroderma was causing?
Well, listening to her lungs, they heard fine crackles at the bases bilaterally. That suggests fluid building up, likely from the kidney failure, but also potentially worsening of that underlying interstitial lung disease.
And the kidney damage itself.
The labs confirmed acute renal failure, no question. Her urea and creatinine levels were way up. Creatinine was 3.8 milligrams per deciliter, which is a huge jump from normal. Plus, her urine showed significant protein in blood, confirming damage to the kidney's filtering units.
And could they visually confirm the underlying vascular problem, going back to that first symptom, the Raynaud's?
Yes, they used a technique called nail fold capillaroscopy. It's non-invasive, basically looking very closely at the tiny blood vessels at the base of the fingernails with a microscope.
And what did they see?
Classic scleroderma pattern. Some capillary loops were massively dilated, stretched out, and critically, there were large areas of dropout places where the capillaries had just been completely destroyed, vanished.
Wow.
This microvascular destruction is really the engine driving the whole disease process, the fibrosis, the organ damage. It's why the kidneys finally gave out in this crisis.
Okay, so you have this storm of symptoms: skin, GI, lungs, kidneys, vessels, all hit. Autoimmune diseases are notorious mimics, though. How did the team sort through the possibilities and land definitively on scleroderma?
That's always the challenge in rheumatology, right? Working through the differential diagnoses. Lupus, or SLE, was definitely on the list
Why lupus?
because it can cause both skin problems and kidney disease, sometimes severe kidney disease. But Nancy didn't have the key markers for lupus. Her anti-dsDNA antibody was negative, and she didn't have that characteristic butterfly-shaped malar rash on her face.
Okay, so lupus seems less likely. What about conditions affecting muscles?
Dermatomyositis was considered. It can have skin features too, but she didn't have the main signs. Significant weakness in the muscles closer to the trunk, like trouble getting up from a chair or lifting her arms, and no heliotrope rash, that purplish rash around the eyes.
Any overlap with arthritis?
Well, she had some joint stiffness, but it was minimal. Nothing like the aggressive joint inflammation and erosion you typically see on x-rays with a severe rheumatoid arthritis overlap. So that was ruled out too.
So after eliminating those, the diagnosis became clear: systemic sclerosis. But they specified it as the diffuse cutaneous subtype, DCSSC. What locked that in, particularly from the lab work?
The specific antibody profile was really the key. Her ANA, the anti-nuclear antibody, was positive, which is common. It had a nucleolar pattern, which is often seen in scleroderma.
But the crucial one.
The crucial one was the positive anti-CL70 antibody, also known as anti-2-poisomerase I. This antibody is strongly associated with the diffuse, more aggressive form of scleroderma.
And that fits her picture perfectly.
It fits perfectly with her rapid onset, the extensive skin involvement, and critically, the internal organ problems like the ILD and the renal crisis. Importantly, the anti-centromere antibody, which usually points to the more limited, milder form, was negative.
So that anti-CL70 positive result basically confirmed they were dealing with the most severe subtype.
Did imaging help confirm the extent of the internal damage?
Oh, absolutely. The imaging painted a clear picture. A high-resolution CT scan of her chest in HRCT showed definite interstitial lung disease. You could see ground glass opacities, sort of hazy areas, and early signs of scarring or
In
fibrosis.
her heart and esophagus.
An echocardiogram confirmed she had mild pulmonary arterial hypertension, PAH, meaning the pressure in her lung arteries was elevated, and a barium swallow test confirmed what her symptoms suggested. Significant problems with esophageal motility, how the esophagus squeezes.
So the evidence was overwhelming. Aggressive, diffuse SSC attacking multiple systems.
Simultaneously, yes. Okay, so Nancy's in the ICU, BP through the roof, kidneys failing. The immediate management must have been intense. What was the absolute #1 priority, the life-saving intervention for this scleroderma renal crisis?
The absolute priority was getting that dangerously high blood pressure down, specifically the kind driven by the renal crisis. And for that, ACE inhibitors, angiotensin-converting enzyme inhibitors, are the cornerstone, drugs like captopril.
Why ACE inhibitors specifically?
Because they directly target the renin-angiotensin system, which goes into overdrive during the specific crisis. They rapidly lower blood pressure in a way that helps the kidneys recover. They are truly life-saving in this situation.
Makes sense, but it's tricky, isn't it? Autoimmune diseases often get treated with steroids to reduce inflammation. But I remember you saying they kept the steroid dose minimal for Nancy. Why that caution?
That is probably one of the most critical points in managing scleroderma. There's strong evidence, unfortunately, that giving high doses of corticosteroids can actually trigger or worsen a scleroderma renal crisis.
Really, that seems paradoxical.
It is. It's a unique situation in rheumatology. So the team had to walk a very fine line, use just enough steroid to manage some of the other inflammation, but keep the dose low enough to avoid making the kidney situation worse. The ACE inhibitor was the priority for the kidneys.
Right, so stabilize the kidneys first. But then they had to address all the other damaged systems, the lungs, the blood vessels, the GI tract. That must have meant a lot of different medications.
It's a complex regimen, definitely. For the interstitial lung disease, the goal is to slow down the scarring. That often involves immunosuppressants, drugs like mycophenolate mofetil, maybe even cyclophosphamide in severe cases.
And for the lung pressure issue, the PAH.
That needs different drugs. Specialized vasodilators that open up the blood vessels in the lungs. Things like endothelin receptor antagonists, bosentan is one, or PDE5 inhibitors like sildenafil.
Okay, and what about managing the symptoms that started years ago, like the Raynaud's and the reflux? Those don't just go away, right?
No, they need ongoing management. For Raynaud's, calcium channel blockers like nifedipine are often used to try and improve blood flow to the fingers and prevent more ulcers. And for the severe reflux and swallowing issues, high-dose proton pump inhibitors, PPIs like omeprazole, are usually necessary.
It's just staggering. One disease requiring interventions across, what, 5 or 6 different medical specialties?
Easily. If you list the domains involved, just in Nancy's case, skin, vascular, renal, respiratory, gastrointestinal, and the underlying immunological driver, it's truly systemic.
And that doesn't even cover the supportive care.
Right. Plus, things like patient education, meticulous skin care, avoiding cold, physiotherapy for mobility, maybe even bone protection meds because of long-term treatments. It's comprehensive.
What an absolutely incredible story from start to, well, this critical phase. We started this deep dive talking about Nancy, 38 years old, whose main issue 5 years ago was cold fingers. And we end with her diagnosed with aggressive diffuse cutaneous systemic sclerosis, positive for that CL70 antibody, fighting multi-organ failure triggered by a renal crisis. That acceleration from chronic to acute in just 2 weeks, that's terrifying.
It is. And what really stands out, I think, is having both severe lung complications, the ILD and the PAH, developing alongside the renal crisis. That combination is particularly aggressive. It underscores why that anti-CL70 antibody is such a warning sign, demanding really close, proactive monitoring.
So this case is a powerful lesson.
Absolutely. It demonstrates vividly why symptoms like skin tightening or worsening Raynaud's are never just skin issues in this context. They can be the slow countdown to an internal catastrophe. Physicians have to be vigilant, constantly monitoring kidneys and lungs for that sudden drop-off, that cliff edge, especially in DCSC.
A really powerful reminder that sometimes the biggest threats build slowly over years, but can strike with devastating speed. Thank you so much for walking us through this incredible complex case.
My pleasure. It's an important one to understand.
Until the next deep dive, keep learning.